get this session started. My name is Kevin Ghassemi. I'll be moderating this session on upper GI disorders, and I figured since I'm up here, why don't I speak first? So I'm going to be giving a talk on an evidence-based approach to PPI use in 2019. So I have no financial disclosures. We'll be talking about indications for PPI use, the appropriate use of PPIs that are not based on FDA indications, adverse effects and safety concerns, and then finally, the AGA has some best practice recommendations, which I will go over with you. So just to make sure everyone's mentally ready for this last session, I have a couple of cases we'll start with just to get you thinking. So we have a 64-year-old man with a 10-year history of GERD. His main symptom was heartburn with some dysphagia. He underwent an EGD, and there was LA Class C erosive esophagitis. This was documented to have healed on a follow-up endoscopy after 8 weeks of twice-daily PPI therapy, and now he's doing really well symptomatically on a once-daily dose. However, his primary care provider told him that he should stop his PPI because there's a risk of dementia. And so he stopped it, and he had really bad rebound heartburn. So then the PCP told him to take ranitidine, and he took pretty high dose, 300 milligrams twice a day, with only 50% symptom control. So now he's back on his usual PPI dose and is feeling great, but he's worried. So what would you recommend that he do? Tell him studies on dementia are low quality. Don't worry. Stay on the PPI at the current dose. Try a half dose of his omeprazole. Refer him to a surgeon for a fundoplication, or switch to a PPI that has a lower dementia risk. All right, so most of you recommended staying on a PPI at some dose. I won't say that there is truly a correct answer here, but I think that A and B are excellent options. Okay, feeling pretty good there. Let's do one more case, and then we'll get into the meat of the story. 71-year-old woman with a history of 3 gastric ulcers within a 5-year time span. Each time she presented with dyspepsia, although on the first episode she did have melena. And the first episode was attributed to baby aspirin use. However, on the other 2 episodes, she did not take any aspirin or NSAID medications or other supplements that are known to have antiplatelet activity. Each time she was treated with a PPI, and an EGD confirmed that there was healing of the ulcer. She's had 3 negative H. pylori tests of various ways, including serology, stool, and biopsy. And one time when she was off her PPI, the gastrin level was normal at 18. And in between these episodes, she's asymptomatic. So now she comes back with recurrent dyspepsia, and again, no triggers were identified. She had another EGD, and you can see the image on the right, a clean-based antral ulcer. Biopsies off of PPI were negative for H. pylori. She was put on another course of PPI and symptoms resolved. So what do we do next? Indefinite PPI for prophylaxis, indefinite H2 receptor blocker for prophylaxis, do a nuclear medicine study looking for a gastrinoma, or just no prophylaxis whatsoever. Okay. So most people chose to stay on a PPI indefinitely. I don't know what the right answer is here. And in fact, after discussion with this patient, we actually chose the one that no one chose, which is to not do anything and just deal with it when it comes up again, because she could go years without symptoms. So now that I got you thinking, let's talk about PPI use. So here's a list of what the FDA says is appropriate indication for PPI. Healing and maintenance of erosive esophagitis, gastroesophageal reflux disease, including non-erosive disease, peptic ulcer disease, treatment of H. pylori in combination with antibiotics, and finally, treatment of hypersecretory conditions, including Zollinger-Ellison syndrome. There are many other uses for PPIs that don't fall under that FDA list, including treatment of dyspepsia, eosinophilic esophagitis, prophylaxis for stress ulcers, treatment of complications of cirrhosis such as prevention of post-banding ulcer bleeding and varices, and finally pancreatic disease complications, and we'll get into all of these things in a little bit more detail soon. So In a review that you can see the reference at the bottom, this was a systematic review going over a variety of guidelines and randomized controlled trials, et cetera, that is a consensus on appropriate use of PPIs. And so this first table on this slide is appropriate use in reflux. So for what we could categorize as, let's say, low-grade erosive esophagitis, the starting dose should be a once-daily PPI, and the duration should be for 8 to 12 weeks. For more severe erosive esophagitis, it should be at BID dosing for 8 to 12 weeks. For non-erosive reflux disease, you would treat with once-a-day dosing to start, and typically the treatment would be for 4 to 8 weeks. Long-term management, the dose can vary, although usually you want to do once a day or maybe even once a day with a half dose now that there's all these over-the-counter preparations, and the treatment again would be long-term here. For Barrett's esophagus, the dosing should depend on whether you are going based on symptoms or if you do a pH study to document that a certain level of acid suppression is adequately doing its job. And again, that treatment would be long-term. And then finally, for extraesophageal manifestations of reflux, typically twice a day, although once a day has also been evaluated and seems to also be appropriate, the treatment duration should be for at least 12 weeks. Now, there are a variety of other scenarios. For eosinophilic esophagitis, the duration is typically 8 to 12 weeks before either a dose reduction or possibly discontinuation. For H. pylori eradication, as the only reason for using the PPI, it would be for 2 weeks in addition to the antibiotics. For non-H. pylori peptic ulcer disease, typically for low-risk stigmata would be once a day for 4 to 8 weeks. With high-risk stigmata such as a visible vessel or adherent clot, it would start with twice a day. Zollinger-Ellison syndrome is typically twice a day, and it would be long-term use. For stress ulcer prophylaxis, typically given IV because these patients are usually much sicker in the ICU, and again, it would only be while they're in the ICU. For bleeding peptic ulcer disease, you have the IV bolus followed by a continuous infusion for 72 hours, and that's based on guidelines. Other scenarios include uninvestigated dyspepsia in patients who are less than 45 years. Typical dose would be once a day for 4 weeks. For patients with functional dyspepsia, and this is one of the MOC questions, it would be once a day for 1 to 2 months. For prevention of NSAID-induced gastropathy and ulcers, as long as the patient is on that NSAID, once-a-day dosing is appropriate. Steroid treatment, there really is no need for PPI use unless the patient is also on NSAIDs. For antiplatelet therapy in patients who are at high risk for peptic ulcer disease and bleeding, it would be once a day as long as they're on that antiplatelet medication. And then finally, for anticoagulants, there's no need unless they're also on an antiplatelet drug. And then this is the last table for appropriate use, so it's quite extensive. I had to break it up. For portal hypertensive gastropathy, there's no need for PPI use. For variceal banding or sclerotherapy afterwards, it's usually once a day for up to 10 days, the amount of time that it takes for the ulcers to heal significantly. In acute pancreatitis, there's no need, but in chronic pancreatitis, in patients who have steatorrhea that doesn't respond to enzyme replacement therapy alone, this would be warranting once a day long-term use. So moving on from appropriate use, let's just talk about use overall. And the fact is that PPI use has increased over the years in a variety of settings. Ambulatory has increased about 2% over the last 5 years or so. But when looking at the indication for use, only 16% of patients who are getting these outpatient PPIs had a documented indication. In the emergency department, there's basically been double the use in a 10-year span, and in the hospital setting, almost a double use in, again, a 10-year span. So these are being used more and more, and this occurs in the setting of a bunch of safety concerns that have shown up. Now, I've given talks on PPI safety in the past. I won't go into it in too much detail given time, but just to go over the main categories. Kidney disease, this is based on the idea that PPIs can cause acute interstitial nephritis. It seems to be an idiosyncratic reaction. However, it's thought that for some patients, persistent PPI use leads to a low dose or a low level of AIN, so I guess subacute AIN, which long-term can lead to fibrosis, chronic kidney disease, and even end-stage renal disease requiring dialysis. And Two major retrospective studies in the past few years have really highlighted this, and patients are well aware of this because it's been seen on various news agencies and news reports that showed compared to H2 receptor blocker use and acid suppression non-users, there was an increased hazard ratio for PPI use with regard to kidney disease. However, again, these studies are retrospective, and so some of the baseline characteristics differed among the different groups, particularly with regard to cardiovascular and antihypertensive medications. And they also did not account for certain other comorbid conditions such as diabetes mellitus, which, as we all know, is a risk factor for chronic kidney disease as well. The other thing I wanted to point out is with this graph here, you can see that up until about 2 years, the risk seems to be rising, and it's hard to read on the side, but these are just different markers of chronic kidney disease, whether you're looking at the creatinine, the GFR, or the need for dialysis. And after about 2 years, the risk seems to drop, and it's thought that that might be because if you're not going to get it by a certain amount of time, chronic kidney disease, the risk drops because you might not ever get it. So in the patient who's been on a PPI for 5 years, 10 years, and they're worried about this because they just heard about it, yet their GFR is normal, they're probably not going to get chronic kidney disease, at least from ongoing PPI use. With regard to cardiovascular disease, looking at PPIs and clopidogrel in particular, the potential mechanism here is that they both compete for the same liver enzyme, the CYP2C19, and clopidogrel is a prodrug and needs to be metabolized into its active form. So if you are competing for this liver enzyme, you might have reduced clopidogrel activity and increased cardiovascular events. Another potential mechanism where PPIs could influence cardiovascular health is this ADMA, which is an eNOS antagonist, and PPIs increasing ADMA levels could affect vascular dilation. However, in human studies, because it was shown in my studies that this level was increased, we didn't see increased ADMA levels in humans. And furthermore, studies looking at flow-mediated vasodilation among PPI users, there wasn't any impairment in that regard. But let's look at it more from the clinical population-based level. A systematic review about 10 years ago found that there was an increased risk of cardiovascular events among all types of PPI use when combined with dual antiplatelet therapy. However, these studies that they looked at in the systematic review were all observational. In the COGENT study, which was a randomized trial of clopidogrel plus or minus PPIs, there actually wasn't a difference in the cardiovascular events between the users and non-users. And then in a more recent retrospective study looking at the risk of myocardial infarction among people who were taking PPIs, there was an increased odds ratio. However, again, this was an observational study. They didn't account for a variety of comorbid conditions, including insulin resistance and obesity. So it could have been that PPIs were kind of the innocent bystanders, so to speak. More patients who have these other comorbid conditions are likely to be more obese and have an increased risk of GERD in taking these PPIs. So it's hard to really base decisions for whether or not to use PPIs on these studies that aren't quite sound. Bone mineral density and osteoporosis. So this has probably been the longest standing concern, and there were early reports that linked PPIs to bone fractures. Most of these studies were case control. There was a large study involving the U.S. nurses, 80,000 subjects, that found that there was an increased risk of hip fracture in the PPI group. However, when they accounted for other risk factors, including smoking, that odds ratio became insignificant. There was a more recent Canadian prospective study looking at PPI users and non-users, and they followed their bone mineral density over a period of about 10 years. And there was no difference in the rate of bone mineral density decline among the two users, although the PPI users, for some reason, at baseline had a lower bone mineral density. While that can't be explained, again, that 10-year follow-up shows that there wasn't any change in the rate of decline. And more recent studies have shown no association between PPIs and bone strength or structure. So 15 years later, we still don't really have an ironclad answer for this. With regard to other minerals, including magnesium, some early studies showed that there was a reduction in the magnesium level among PPI users, although you can see here that the reduction was very small, 0.02 milliequivalents. This effect is accentuated with the concomitant use of a loop diuretic, and the risk only seems to be around in patients who are taking the PPI longer than 6 months. There have been some more recent studies that show that there was actually no difference in the magnesium levels among PPI users and non-users, and no difference in the prevalence of hypomagnesemia between the groups either. So not only did it not seem to reduce the level, there wasn't an increased risk overall of clinically significant reduced magnesium level. And in these patients who were taking the PPI, the loop diuretic didn't seem to make things worse either. Dementia is probably the most bothersome or worrisome for patients nowadays, since it is relatively recent. And this came about because of two German-based health insurance queries that found that there was an increased hazard ratio among the patients who were taking PPIs. Again, these were retrospective studies, and they found numerous confounders. However, in their study, when they accounted for them, the hazard ratios actually got worse. Potential mechanisms for these include increased beta amyloid levels in the brain in mice after PPI treatment, and it's been shown that some PPIs can cross the blood-brain barrier, so it's thought that maybe reducing the acidity level in the lysozymes might impair the degradation of the beta amyloid and contribute to dementia. There have been more recent studies after those health insurance database queries, including a retrospective Finnish study that looked at the risk of Alzheimer's dementia and found that there was no difference in the risk among PPI users versus non-users, and there was no effect depending on the duration of PPI use. In a prospective Danish twin study, there was no difference in the cognitive decline between PPI users and non-users in a 5-year follow-up. And then in a US study, which is the most recent one, which included patients who were using PPIs for up to 5 years, there was no increased risk of dementia even at 7.5 years after having started the PPI. So even in patients who had discontinued and were followed, there still wasn't an increased risk of dementia. Infections, including pneumonia and C. diff, the strongest association for infections with PPI use is actually in the short term, as opposed to all the other conditions where it's long term. There doesn't seem to be an association after 6 months. However, there's a lot of heterogeneity in the study, so it's difficult to really explain the findings overall. And then with C. diff infection, the thought is that if you inhibit acid, it might allow the spores to take on a vegetative form. And there were some early studies that showed an increased risk of C. diff infection among both PPI and H2 receptor blocker users. However, larger studies have not shown an association. And so currently the guidelines, including among those from the Infectious Disease Society of America, does not recommend avoiding PPIs just for prevention of C. diff. So I want to finish off with what the AGA has provided, which is some best practice recommendations, and we can divide this into the do's and the don'ts. So there are about 10 of them. Among the do's, they recommend that for patients with reflux and acid-related complications, PPI should be taken for short-term healing and then also can be taken long-term for control of symptoms. In patients who don't have any complications related to reflux and respond to PPI, attempts should be made to lower the dose or even discontinue the PPI. For patients with Barrett's esophagus and symptomatic GERD, PPI should be continued long-term. For those who have Barrett's but do not have symptoms, consider the use. And the rationale here is that may not be great evidence that long-term PPI use in Barrett's patients who are asymptomatic is helpful, but there's also very little downside based on the lack of good evidence to suggest long-term safety issues for taking the PPI, so consider that. In patients who are at high risk for NSAID-related ulcer bleeding, the patients should be taking the PPI as long as the NSAID is taken. And for those who are taking long-term PPIs, we should be periodically reevaluating to make sure that the lowest dose that's effective to control symptoms is used. And then the 4 don'ts. Don't use probiotics to prevent infection if you're taking a PPI long-term. Don't raise the intake of calcium, vitamin B12, or magnesium beyond the recommended daily allowance if you're taking PPIs long-term. You don't need to routinely monitor the bone mineral density, the creatinine, the magnesium, or the B12 level. And finally, there's no need to try to pick one PPI versus another because of potential risks associated with one specific PPI. And the rationale for that is that originally it was thought that omeprazole and esomeprazole were more risky when it came to the interaction with clopidogrel, but other studies have shown that that's not the case. So finally, just to summarize, PPIs really are valuable in treating a variety of acid-mediated upper GI disorders. There are possible safety issues that exist with long-term risks, but the risks probably are much lower than has been suggested and are overstated. And really, it comes down to, from an individual standpoint, you want to be judicious about the use. You want to use the lowest dose that's effective to control symptoms. And if the PPI is not helping, we should be stopping the PPI and looking for alternative explanations for the patient's symptoms. With that, I thank you.